Good evening and welcome to tonight's lecture. I'm George Kraw along with Rafe Shannon Kraw. This series features acclaimed UC Santa Cruz scientists and technologists who are grappling with some of the biggest questions of our time. Tonight we tackle the question of how to peer into the human body to produce images and other data that can help care providers give a good clinical diagnosis and the challenges of doing this safely. We're going to learn about technologies and techniques to build low radiation diagnostic tools that are safer for both patients and clinicians. Some of these technologies are being developed right now at UC Santa Cruz's Radiological Instrumentation Laboratory. Before we begin, I would like to share a few details about the event tonight. We are using a webinar tool, so there is no chat function. We will have an opportunity to answer your questions at the end of the program, and we invite you to submit your questions into the Q&A box at any time. Tonight's event will be recorded and will be available on the UCSC Arts and Lectures YouTube channel. Our conversation tonight will be moderated by Professor Marco Rolandi. Professor Rolandi is the chair of the Department of Electrical and Computer Engineering at UC Santa Cruz. He is also the co-founder of the Kinetech Medical and Cruz Foam. Marco received his PhD in applied physics from Stanford University, working on novel nanofabrication strategies and carbon nanotube devices. His research focuses on bioelectronic systems and devices, biological control in regenerative medicine, and synthetic biology. His work on bioelectronic transistors and Chart electrosensors has been highlighted in the New York Times, Washington Post, New Scientist, Popular Science, and several other journals. He is currently leading a multidisciplinary project sponsored by the Defense Advanced Project Agency on bioelectronic control in wound regeneration. Welcome, Professor Rolandi.
Thank you, George, for the kind introduction, and it's really exciting to be here. Actually, what's really exciting for me is to be able to introduce one of our youngest faculty in the Electrical and Computer Engineering department. You know, as the same way as a faculty, you really take pride in the successes of your students. As department chair, you're really most proud of the successes of incoming faculty like Shiva, Professor Bassadez, who started with us about 2 years ago, transferring from University of Illinois Urbana-Champaign, and she's really been on fire. And Professor Bassadez started her career as an electrical engineer in Canada, and then she moved to Stanford University to do a postdoctoral fellowship in imaging in the medical school. And we were lucky enough to have her join our department about 2 years ago. And their work really focuses on applying engineering principles to medicine. And I was just looking up a few minutes ago, like what are the 5 biggest advances in medicine in the past few hundred years? And starting with vaccines, which we all know are really important now. Then there is anesthesia, penicillin or antibiotics, organ transplant, and medical imaging. And medical imaging is an advance in medicine enabled by engineers like us. And that's what we're going to hear about tonight, is how can we make medical imaging better? How can we make it more efficient? And how can we make it patient-friendly? And so, Shiva, I leave the room to you.
Thank you so much, Marco. Thanks a lot for the introduction. Okay, so let me share my slide. And then, okay, should I start? So hi everyone. So then today we are going to talk about peering to the body, and then I'm going to tell you how I'm just trying to do in my research to make it more sensitive so that we can reduce radiation dose or just like reduce the time of imaging and then make the procedure safer and then more applicable. So then before I want to talk about what are the different imaging modality that today I'm going to talk about, because like most of you have heard of, X-ray imaging, ultrasound, mammography, and then magnetic resonance imaging. And then today we are going to do mostly radiation using X-ray, and then we move on higher energy for positron emission tomography. So then in order to understand some of the things that we utilize physics to make like engineering more helpful, I'm going to talk about a little bit interaction of radiation with matter, which is like as if the alphabet of like our work. And then I talk about the principle of X-ray imaging. Then I highlight the research that I'm doing in my lab regarding this. And then we move a little bit in energy to higher energy. And then we talk about positron emission tomography. So it's just like still positron is going to be emitted, and then we are having 511 keV. Let's say, for example, for mammography, we are in the range of 25 keV. In chest, we are in 70 to 100 keV. So in PET is 511 keV, is higher energy. And then I highlight the current research in my lab regarding positron emission tomography. Okay, so then for X-ray, so then we have mammography, chest X-ray, and then computed tomography is like basically X-ray, but then we are rotating the source, and then we have more detector so that we can have like a tomographic image. And then kind of similar, so then in gamma ray imaging, we have gamma ray imaging, then we have positron emission tomography, which is like, again, the tomography of the gamma imaging, but then we use a positron, that's why it's positron emission tomography to create those gamma. And then we have single photon emission computed tomography. So today we are going to talk mostly about the X-ray, which could be like all of these modalities, and then we focus on PET because as you will see, is kind of the same as gamma and SPECT. It has like some specific hardware, but then the physics of PET is just very interesting. It's all you can do with the detector. That right now maybe doesn't make sense, but I'm going to talk to you about it. So when we want to do imaging, so obviously, let's say in optical imaging, we are able to do like surface. And then the reason that we go to higher energy is because we need to see inside the body. And then kind of in the different imaging modality here in top, we are having like imaging that they are doing more of an anatomy. And then as I will explain, the bottom part is more of a functional imaging. And then we will talk about why. So then in order to do that imaging, we are like having this high energy photon that is able to go through the body, and then based on, let's say for X-ray, different attenuation of different material in our body, we have the contrast in the image. But what is happening when, let's say, we hit the photon, high energy photon, to the matter? So then later, the matter is the patient body, but right now you can consider like interaction of radiation with matter. So then there are different probability of the interaction. In the energy spectrum today we are going to talk about, which is like 25 keV to 511 keV, which is like kind of keV is the unit of this measuring this energy. You could say that two interaction is the most probable. So I always call the first one to my student as if it's photoelectric, is this dedicated photon that is give all of its energy to like the electron in inner shell. So then that's why even the name of it is photoelectric, which is photo, then like the energy is going to be converted to electron. So this interaction is mostly happening in electron in the inner shell of the atom. And then you could imagine that whatever you're shooting here as your primary is going to be the binding energy of the atom minus basically the energy of the incoming minus the binding energy. So then photoelectric, when it happens, photon is going to get absorbed, and then now this high energy electron is moving in the material, and then it ionizes more. So the other effect is Compton scattering. So this one, I call this is the stingy photon to my student, because the photon is coming, but then as if it doesn't want to lose its identity. So it's just giving some energy to like not this time inner shell, so maybe mostly outer shell, and then change direction. So then as a consequence of this interaction, you still have like an electron, which is we call the Compton electron, and then the photon is changing direction, and still there is a photon. So then there is a probability that it's moving around, and then somewhere else again another event can happen, that it could be again either photoelectric event or Compton. So you will know more later why I call this Compton scattering kind of enemy of imaging, because photoelectric event, you know what is happening. Because if we assume, let's say everything is photoelectric, then you can say whatever is the energy of photon, if you're successful in engineering your system to measure that charge, then you can guess what it was. But then if Compton scattering is happening, first of all, since this angle of, changing direction can be arranged, so then you don't know the primary photon where it was. So imagine that, let's say, for example, a chest that you shoot X-ray and then you have a panel behind, the patient, then if it's changing and scattering inside the body, so then it's really hard to make sense of where was the photon is coming. And then people, they used some collimator. You could imagine as if it's a material that has some holes, so that if the photon is going in direction, it attenuates it. But then that means that you have to increase the dose even further so that you compensate for that. So then for now, if it doesn't quite make sense, accept from me, we don't like this Compton scatter when the photon is changing direction and it doesn't give all of its energy, and then there is a probability that maybe later it again interacts with matter, and we would love to have photoelectric effect. But because of the nature, any material based on their atomic number, based on the density, they have a probability. So then there is a chance for photoelectric effect, and there is a chance for Compton scatter. So you see that now the incident radiation is coming. You have your material, which could be like patients, but then now as if I'm telling you a little bit about as if whatever is coming out of patient is going to be the input to the detector. So then now imagine that the incoming photon is coming, and then we have this detector. Right now is just this box. and then it creates some charge, because if you remember both time I mentioned that there is going to be some electron that they are going to move around, and then they are high energy, and then they are going to ionize more electron hole pairs, and then as an electrical engineer our job is to collect that charge. Okay, so then we get the signal, and then in X-ray, for X-ray imaging, let's say that now we have an X-ray tube, which is the source that we shoot X-ray. We have patient, and then you see that like we are shooting the X-ray, and then you see the red one is whatever that is happening, that is a scattering event. And then like based on the blue one, whatever is the object and the material, you're going to have some attenuation. So let's say in our lung, since it's more air, is going to be less attenuating, but our bone structure is going to attenuate more. And then the output signal, the photon that is coming out of the patient, is going to be less or more. And then you're going to have a detector, and then you're going to just detect that charge, and then you're going to create an image. So then we have like mammography, we have computed tomography, and then like the kind of the basic of readout of that charge, it has the same really technology that you have in your, similar to the flat panel in our monitor, or even it could be kind of slightly different, but the concept is the same, even whatever we have in our cell phone. So then the point is that you have an array of pixels, and then that array can have an architecture of, you know, transistor to get that charge. They can be like amplifying, or they can not just amplify whatever you generate, and then you create, you know, like based on how much charge you're generating in each of these pixels, then you're going to create an image. So then, but before that charge, in order to absorb this photon, because, you know, in our camera, we have a, you know, like a detector based on silicon, because it's more optic. And in optic, we are talking about something 1 to 2 electron volts, but then now we are talking about X-ray 25 keV, kilo electron volt. So obviously, a thin layer of silicon is not going to absorb. So then you don't want to come up with a scenario that you're shooting X-ray and it's just like transparent through the material. It should absorb the part of energy. So then we have 2 different technology that is getting like the interaction of photon with the detector. One of them is direct conversion, which means that, for example, you have a semiconductor detector or a gas detector that you just dope it with some material that directly ionize, and then it's converted to charge, and then you have an electric field and you just collect the charge. Let's say here, semiconductor, we have here, this is photon coming, we have electron hole pair, and then I have like a positively and negatively electrode. So then the positive goes to like one electrode, and then the electron, they go to other. Okay, so that's why it's direct, because it's directly like detect high energy photon. The other one is indirect. The reason that is indirect, because we have this middleman process. Is like the high energy converted to visible, and then now we are very like a strong invisible technology. So then we can use whatever that we are using in optics, because now the high energy photon is converted to optical photon. So then in this process, we are using a material called scintillator, different type of scintillators. And then that is converting the high energy photon to visible light. And then what is very important, again, we have to make sure that whatever is the emission of that scintillator is matched with the absorption of the detector. Because all the material as a detector, based on their band gap, which is like consider material properties, like they are very sensitive to a specific wavelengths. For example, here I have a material that is very sensitive. The peak of sensitivity is at 400 nanometer wavelengths. But then if I have a scintillator that it generates light in red, so then if I put these two together, then my detector is not going to read anything because it's not sensitive to red. So then part of the research is that how you dope and how you make up the detector, that if the emission of your scintillator has like this kind of a spectrum, you make sure the quantum efficiency and absorption spectrum of your detector is matched with this emission. Okay, so then what am I doing? So then now there is different things that I'm doing. So then, okay, so then Kevin, I'm sorry, like we have not a question, a comment that the battery was backward, which is really good. Like, I think that we have someone paying very much good attention, because you see here we have a negative and then we have positive. So then the negative one should absorb holes. So then here you see that the holes, they are coming here. And then basically now, based on what we were talking about, we are trying to make the device structure to collect this electron hole very well, and then to make sure that if we have to alloy the semiconductor, we do good job to make sure that if it's direct, to make sure that it has really good quantum efficiency, that it can have all the electron hole pair collected. Because you see, when we go direct with a specific material, you have to go through a specific thickness. And then the problem is that if you go for a thicker layer, then, you know, how do you prevent those electron hole pair before they get you know, trap or something happen to them? You want to make sure that they find, you know, their path to the biasing electrode. So then, like, kind of as if in direct conversion, we try to work on the detector to make it faster and to improve the quantum efficiency of the detector, and then find a way to make the device more sensitive, that I talk a little bit. And then for the indirect conversion from the detector side, we are trying to like exactly match the absorption with the emission of the scintillator. Okay, so then now, like, I started working basically in amorphous selenium as a training of background of electrical engineering. We were very trained in silicon. So in 2009, I got introduced to selenium, and then I kind of liked it. Why? Because this is a technology very mature, has been like in photocopy industry before it gets replaced. And then, like, we have flat panel direct conversion detector for mammography made of amorphous selenium. And I tell you why I like direct conversion. Because in direct conversion, you can see here, when the photon is interacting and it creates that electron hole, since you have the field, almost the same area that your charge gets generated is going to be collected. So then for you later in your detector, you have a good estimate of where was the original direction of the photon. But then for scintillator, remember, when you create light, light goes isotopically everywhere. So then you have to come up with more ways of making sure that the pixel that you have underneath of your scintillator, you find basically the center of the mass when the photon interacted. So then kind of, you know, you could say in general, everything we have to go to the detail because there is so many parameters, but in general, if somebody tell you direct conversion has a better spatial resolution or indirect conversion, you go with direct conversion, because direct conversion, you see the charge get generated, get collected because of the field on the same pixel that is generated. This is kind of safe. So then is a direct conversion, which I like as an imaging person, I was like, if I want to go to higher resolution, because, you know, like for mammography, I wanted to make sure that we are able to see the macro calcification. So selenium is good. And then is a wide band gap material, because when you talk about the detector, you want your detector at dark, as if when there is no X-ray, to be very sensitive. And then the other thing is that it has like avalanche multiplication. What does it mean? It means that when you shine by itself, it can for one photon generate more charge, which is good for us. So then this was very nice. I put this here because this is a company in Japan. As an electrical engineer, CCD, the charge couple device, was like my, like a device that I was thinking they're really good, and then they're really low noise. And then they had a publication of a camera that it was made of amorphous selenium with some other layer of material. That here the picture is like at dark. They call it like a picture taken moonlight in a room. And then A is this device and B is a CCD. So then like this is very interesting. And then like in my PhD, we work on like making amorphous selenium for mammography, and we show that yes, we can have improvement. And then that's why there is so much potential for this material. And then when I came to UCSC, I was like, we have to make a facility to be able to fabricate amorphous selenium. Since it has high vapor pressure, it's not something that you can put it in any thermal evaporator. And then luckily, now we have like a thermal evaporator, which is dedicated to selenium. And then we have an E-beam that we can do other layer for like electron blocking layer, hole blocking layer, which you could say that, like they are equivalent of this other layer of material. Why? Because you want to keep your detector at dark to have very low dark current. But then if I was just telling you peering into the body with less risk, how we are able to do that? If we want to lower the dose, it means that for one photon, instead of not putting 10 photon in the patient, then you want to have one photon, but then still you need to have 10 charge. So then selenium is really good compared to silicon, that in amorphous form, the electric field required to initiate that process of impact ionization, that, the charge has such an energy that it hit the atom, and for one, like photon, you can create multiple electron hole pair. That happened at lower field compared to amorphous silicon. That's because the phonon scattering, which is a process that is happening in the material, is less. So as if it gain energy, and as it's just a scatter and is lose energy, at the end, like the process of loss is better in selenium compared to silicon. So then the threshold that you need to get to avalanche region is lower. But then now you want to apply a high electric field across the device. So whenever we apply a voltage, we have a current. So then in selenium, this is important because mostly it comes from the biasing electrode. So then the junction in solid state work and in semiconductor technology, just engineering this like band gap of different layers is important. At the same time, since when you shine light, the conductivity of the selenium is changing, then it's really important that those layers, like right now I show you hole blocking, and then in electrical engineering, we almost all the time simplify things, let's say with a resistor and a capacitor in parallel together. So then my point is that in addition to engineering the band gap, we want to make sure to find some material that when the field is going to drop more now across this guy, because the conductivity of this guy is just reducing due to like the X-ray. So then you want to make sure that this doesn't go to dielectric breakdown and it survives. So then this is type of research that I'm doing in my lab, and then we are alloying this selenium to make sure that even within the selenium, we get the best electrical and optical properties, and then what kind of other good layer they are good to make this detector perfect so that we can lower the dose and increase the sensitivity. So then here I show you that we have been able to demonstrate that the detector can go to impact ionization. The blue is just like a normal transient current due to at this point it's just we shine laser. So then in a laser, and then you see red and black is I'm increasing the biasing voltage. And then now we are not in avalanche region, but you see the transit time becomes shorter. And then this one is just like the impact ionization, that it goes exponentially high, and then you see the signal level is higher. But then now our goal is to make this to something that is stable, is practical, and then we can like really make an impact in a medical imaging device. And then stay tuned, because we wanted, in order to make an imager, we want to have the readout electronic. So then I talked to Barracks Imaging, which is a local company, and I was able to successfully excite them. So then they donate like a TFT, which is thin film transistor, is like exactly at the beginning, I show you an image of a pixel array that they provide to us, that now we can build the detector on top of it, and then they are going to help us to make an image. So then we are able to show and demonstrate the capability of the detector. And at the same time, because comparing this thin film transistor with the CMOS, which is the complementary metal oxide, is like two different technology. One of them has higher electronic noise, but then is the lower cost, and then you can go larger area. But this one is based on silicon, like crystalline, which is like a smaller pixel and is lower noise. But you see, this is really to the scale. This is like, I think is 20 centimeter by something, but then this one is like 2 centimeter by 2 centimeter. So then this one we can fabricate, and we can do things for like when we really need high spatial resolution. When I say high, it can be like 7 micrometer to 25 micrometer. And this one is like 75 micrometer to 150. I think the panel they provided to us is 150 micrometer. Okay. And then where am I going? Because now that we have this facility, we can make dual detector, which means that as if we can have 2 detectors considered in a simple form on top of each other. And then we can make, high energy and low energy kind of separated, especially, during pandemic, we were having so many chest X-ray. And then this is really important, because I'm really interested in opportunistic screening. This is very funny. I started thinking about it after I had my baby, because I felt like my bone density, it totally changed. And then I was just talking that, I feel like I'm not the person before. I wish if I had like my bone density, because before pregnancy, I had an X-ray image. And then after my pregnancy, like 1 year after, I had some X-ray for like kidney stone or some other reason. And then I was like, what if they could give me my bone density for free? And then this has so many applications, because, let's say that if you're having a chest X-ray, and then we have the image of heart here. And then for a heart disease, if you have calcium in your coronary artery, this is really good if you could like detect that. So then now I'm just trying, to work with Dr. Adam Bank from Stanford, who is an expert in CT, to see how we can utilize this detector to improve the contrast and material decomposition for doing opportunistic X-ray. And then now I'm in a good point, because I'm going to wrap up whatever I told you about X-ray imaging and amorphous selenium, because I'm going to go to higher energy. So then in summary, we have I can say, to my knowledge, it could be one of the few, if not only, fabrication of amorphous selenium in a research school, that we are able to make a detector with all the layers utilizing amorphous selenium. We developed the recipe. We are able to fabricate amorphous selenium. I have my wonderful postdoc and my PhD student that they are working on this. And then we are working on introducing different hole blocking layer and allowing the selenium to make like kind of close to an ideal detector. And then we are planning to integrate this with CMOS and TFT. So if you have any question, this is a good time to ask. Or you can just a little bit move yourself, and then we are going to go to higher energy. Okay, so if you want to think a little bit about it, so then we can just have another time for the question. So then now I'm going to switch to the positron emission tomography, and then I want to tell you why I was saying, oh, the top imaging, there are more of the anatomical imaging, and then I call the bottom one like more functional imaging. So like in nuclear medicine, which is like, you know, like gamma ray and then PET and SPECT, so then we call them functional because you see in X-ray, we had X-ray source and we had patient and we had detector. But then in gamma imaging, like in this form, we have a detector and the patient. Why? Because the source of radiation is going to come within the patient. Why? Because we are going to come up with some sort of molecule of interest, we call it tracer, and then attach it either to some sort of gamma emitting radioisotope or positron emitting radioisotope. And then what is happening when you inject it to the patient, it goes in the bloodstream, is going to be uptaken, and then like they are going to start, you know, in case of positron emission tomography, the positron is going to annihilate with the electron surrounding tissue, and due to this annihilation, 2, 5, 11 keV back to back, they are going to be emitted. And then this is really nice because they are almost back to back. And then now you can do very interesting things because you can come up with what kind of tracer, what kind of question you are interested, and then attach that tracer with the molecule of, with the positron emitting radioisotope. So then mostly I'm going to tell you, because most of the tracer, like the common one is FDG, which is deoxyfluoroglucose, which is a molecule similar to sugar. And then they take advantage of the fact that since cancer cell, they have high metabolism. So then like as if they need more sugar to reproduce themselves. And then if you just inject this FDG that is attached with, like, let's say F18 is a positron emitter, so then it ends up accumulating more in the cancer area. And so then here, this is to tell you, this is very interesting. The reason that I got interested in this research when I was PhD student attending, you know, conferences, and then I was like, oh yes, I have to do this, and then that's why I end up going to Stanford for this technology, is because as I tell you, it is really highly interdisciplinary, and it's just the beauty of radiation detection, because, you know, in X-ray you need to know the position. Sometimes you need to know energy in some application. For example, I do work in security application and anomaly detection. But then this one, you need to know everything. You need to know energy, you need to know position, you need to know the timing. Because when we are talking about the 2 photons, they are emitted back to back. So how you're going to know which 2 photons to pair to each other, so it's very critical. And then you see that you have to know the chemistry and the biology of the body to come up with like what you want to attach with what. And then the image reconstruction of it is just like its whole world. And then the physics and engineering is like really beautiful. So now, let's watch a video to tell you like how this PET is working, and then I tell you, okay, what am I doing in my lab regarding this PET? So then we have the patient, we inject the tracer, which is that FDG that is attached to like some sort of positron emitting radioisotope. We wait, patient is like usually like 40 to 60 minutes is waiting, is resting. And then this uptake is happening. And then you see that, for example, in bladder or brain, we have high consume of sugar. And then this positron emitting is going to get accumulated in tumor region. And the positron that is going to annihilate with the electron in surrounding tissue. And then as a consequence of this annihilation, there is going to be like 2 photons with energy of 511 keV emitted. So then since it's high energy, like is going to come out, and then now you're waiting, you're taking the image for 10 to 15 minutes, and then you have basically your information. I'm going to see there is like a mistake here. If somebody could tell me the patient is actually, his hand is down, but then in the monitor is hand up. So Kevin, I expected you to figure this one out. But if I want to tell you more about how we make the image, so then here I have exactly the same cartoon as the video, that we have the positron emitter, we have this 511 keV, and then now we are trying to detect. And then you see that timing become very important, because here I'm just showing, you know, like a cartoon, very nice, that yes, this 2 detector is going to be trigger. And then if you connect a line between these 2 detectors, then you know the point of annihilation coming somewhere across this line. And then if you get statistically enough of this line of response, then you can do some sort of back projection, or, you know, maximum likelihood, some sort of algorithm to reconstruct the image. Okay. But why I was saying that this is like so cool, and then you need everything, because like if you say that we have like a black box system, we have photon, we have signal. What are the things that is important? Energy of the photon, time of interaction, exact position of interaction. And then here I show you a spectrum, because when like you get your data, if you're the software engineer, it's just like you get like a list mode data, which is like line by line, giving you some information, the detector ID, because you see here we have like totally in a cylindrical system, we have so many detectors. So you get the detector ID, you get some timing, you get some energy. And then as at the beginning, I mentioned photoelectric and Compton, we have this spectrum that is all this energy of the Compton scatter. So if you don't have energy, how do you know which one was the 511 keV? So then this becomes very important to be able to have a good energy resolution. Why? Because you are interested in the 511. And then if, let's say here you see my spectrum, this Gaussian fits that I have, let's say if your energy resolution is 10%, which means that you are not able to recognize between 511 plus 50, 511 minus 50. So then if there is any Compton scatter is happening inside the patient, which means the photon 511 come, and then a scatter lose 50 keV coming out of the patient with like 450 keV. So then this is a Compton scatter. It was just changing direction inside the patient, but then you're going to consider it as 511 because your system has this poor energy resolution. And this is going to totally blur the image. And then you see that this is very important. So I'm going to explain. So for now, accept from me energy resolution. We want to be sharp, very like good energy resolution. And then this is like the cartoon schematic of what I was telling you. Let's say that here, imagine the origin of this 511 positron annihilation was here. So then 1 511 should trigger this detector, 1 511 should trigger this detector. Then you say, okay, the point of annihilation is somewhere across this line. But you see, it is scattered inside the patient. And then now you are going to get this red line, totally wrong as your line of response. And that's why the image is going to be so blurry. This is not cool. So this is like to show you different technology have different energy resolution. And then this is like that scintillator. For example, one type of it is sodium iodine. And then you see the energy resolution is 20%. Here is not at 511, is like for gamma imaging is 140 keV. But then germanium detector, you know, like you see when I was saying you want sharp. So then this is the good one. And then the other thing is that timing, because I was saying the patient is like lying down and then you're going to image them for 10, 20 minutes. And then you're going to have a least mode of, you know, detector ID with energy time. And, you know, like from the ID of the detector, you can guess the position. So, and then the whole body has an uptake. When these things happen simultaneously, how you're going to pair them? Because see, right now, let's say at the same time, we have these two back interactions. And then if you have like a wide window, either you're gonna get confused which of these points you're gonna connect together. And then if you connect this point and this point, again, the red line, not cool. It's gonna ruin your image. So then that's why the timing is super important. And then you see, this is to show you from whatever is happening, the things that happen. When we say true line of response, this is our friend. The positron annihilate, 2511 is coming, and then we are able to pair them correctly. A scatter, not cool, because you see, it changed direction, and then you still detect it. The dashed line is going to give you wrong line of response. Random coincidence, which means that two different points, so one of them, one of the 511 for some reason get absorbed or just come out of the patient, doesn't hit even the detector, because you see the scanner has a, you know, like finite geometry. So then you detect from each positron annihilation one pair of them, and then randomly, since they happen at the same time, you're going to this dashed line again is going to just like be wrong. So then how we can avoid this, and then why still there is research at a school, is because we want to make the energy resolution better, so that we can reject those scatter, because now we can differentiate between 511 keV or 500 keV. And we want to make that time resolution in 10 picoseconds, because like we want to make it as coincidence to the truth as we can get. And something else is that you see in this cartoon, we say, oh, two detectors, they get trigger, and then you connect them. There is a line of response. Actually, it's not a line of response, it's a tube of response. And by the way, this detector is detecting 511 keV, which is high energy. So then you're going to have a thickness of a material. So then you see here, I show if this is the field of view, the detectors that they are close to the center of the scanner, you have this tube of response. But then as you go out of the center, and then all the, you know, like lesion of the cancers is not going to happen in the center of the body. So then you see now, when this detector and this detector, they get like trigger, there is a possibility for any of this corner, which you see your tube of response is going to be wider. So then this is not cool again, because now the size of the image is going to change as a function of where you are in field of view. And then how we are going to address this, come up with so many innovative ideas to make this detector, we call it depth of interaction capability, which means that instead of having this blue block and have no clue of where the interaction happened, to be able to say, okay, this happened within, let's say 1 millimeter, this happened within 2 millimeter. So then that's like totally its own kind of research area. And then if you have any question, how much more expensive is the type of imaging versus what we have in our direct imaging system? So generally, direct detection is more expensive because like at least right now I'm talking about PET. Let's say for PET, we are using cadmium zinc telluride, which is like commercially available. And then, you know, the technology hasn't been mature to go to a larger area and thick layer. And then they do lots of special things in the fabrication that the cost of fabricating those detectors, let's say, for example, I purchased 4 centimeter by 4 centimeter by 0.5 millimeter of cadmium zinc telluride for $2,000. But then in a scintillator, which is the indirect conversion, since it's a mature technology, the combination of cost of an optical detector plus the scintillator is going to be less. And if I give you a number, because when I started my faculty position, I was like, I really need to make a detector, which I tell you why. And then I had just my startup money. I had no funding. So then I had 500K. So then I calculate that how much is going to cost indirect for like a panel of 20 centimeter by 15 centimeter. I will show you later. So like 2 panel, imagine 20 centimeter by 15 centimeter, 2 panel. So then if you want to calculate the raw material of indirect technology was close to like 400, like not including any, you know, engineering, just pure material. And then if you wanted to calculate it for the CZT, it was like $1 million. So it's kind of almost, at least in this scenario, 2 times more expensive. And then here we have another question or comment. I've had some health issue and have had imaging procedure, MRI with contrast, X-ray, ultrasound, and then CT scan with contrast done somehow frequently for past 6 years. I wonder what the impact is on the body when receiving this type of imaging procedure. Is there radiation harm or harm to cell done when this procedure are done often? So, so for X-ray, for like MRI or ultrasound, they are safe. But then whenever we are talking about X-ray, so it's radiation, we are talking about interaction of radiation with matter, and then it happened in our body, and then this like different probability of interaction is happening. And then based on what is the energy, so then it can damage our healthy cell. That's why for radiation therapy, we are very concerned. So, and then it's just all about the kind of as if combination of the advantages and disadvantages. And then it's really important to consider exactly the accumulation dose over time. And then, and that's why I still believe making the imaging to be low dose is going to be the benefit of patient. Okay, so then now we just talk about that in positron emission tomography. We are very kind of greedy. We want to know everything about the photon. We want to know energy, we want to know time, and then we want to know X, Y, and we want to know Z, because the Z, that depth of interaction, is going to define this tube of response. Okay, so then in order to do that, so then I pick this again, direct conversion. You see that I kind of like direct conversion. And then I wanted to work on like a detector. And then how can I compete with GE or something? Because, you know, they are big companies. And then my like rationale was that I want to make like an organ dedicated. And then I pick head and neck, because during my training as a postdoc, and then when I moved to UIUC, I was just like collaborating with hospital. I've seen so many images of head and neck, and then you see in head and neck, the anatomy is very thin, and then we have our thyroid, and then we have our vocal. So it's not like about just, you know, really what we are doing for therapy is the quality of the life after, you know, therapy. So then we can benefit from having a dedicated high spatial resolution system. So because here I have some images, and then this is the quotation from like the radiologist that, let's say here, is saying, I can't never tell if the activity in patients such as this is along the surface of the vocal cord or has invaded deeper. So then this is super important. So if we are able to make a detector, like a camera, that has this boundary of the tumor very like sharp, so then it's going to totally benefit the patient. So then we were like, let's build a detector. And then we come up with something which is portable, because we don't want to like really create anything with the current workflow of the hospital. And then here are my wonderful PhD students that they have been working with me on this. And then we were saying this is going to be like 2 panel for head and neck. And then you see that is going to come around the head holder. This is going to be the patient, go through the whole body. We just need 10 more minutes of extra lying down. We understand that is still something, but then we are trying our best to make this detector as sensitive as possible to reduce even that time. And then this idea is not our idea, because we have organ dedicated. So I'm going to go through this fast. Don't just like get confused of this busiest slide. Just wanted to show you that we have brain like a dedicated PET, and then we have breast dedicated PET. So then like I propose this head and neck, and I just like justify why for, you know, like decision for what kind of therapy is required, or even like imaging for during therapy. This is going to be like beneficial. And then, yes, we can go with different type of, you know, geometry, but then really being in the hospital, I learned one thing, that in medical devices, design with empathy is the most important, because the patient is already suffering enough. You don't want to add to it. So then you use your engineering hat, come up with innovation to make the device work better for the patient. And then, yes, with having 2 panels, now you could imagine that any 511 that is going on top of my head, it doesn't have coverage because the detector, they are side. So then we collaborate with Dr. Jin Yi from UC Davis, who is the expert in PET image reconstruction. And then we took the advantage of the fact that we have the whole body, as if now our detector is going to be zoomed into the patient. So then now is like as if the problem is you have a poor spatial resolution, no limited angle artifact, and then you want to use that as a prior to solve this high resolution with limited angle artifact. And then this is to show you that, yes, we are working on it to reduce this and then like really preserve the contrast. So then this is a work in progress. And then for the technology is just showing you that if you wanted to go to a high spatial resolution, instead of cutting this scintillator and then wrapping them around a reflector, which is really labor intensive, the direct conversion, you just deposit metal as small as you want, and then you can go like that's the detector, the pixelation. And then to show you the energy resolution, the best in research that I've seen is 10% for scintillator, and then you are able to get 3% with CZT. And then it has really high packing fraction. We are using this flexible circuit. Basically, everything has been designed at like our lab here to show you that, yes, we did. Like actually, we asked for this tiny crystal to be just cut, and then we built something 4 centimeter by 4 centimeter technology in direct conversion, which is using silicon photomultiplier for detecting optic. So this was our design. This is real. This is how I had my first PhD student graduated, and then we compare it with CZT. And at the end, we decided to use CZT because I got a grant that now I could afford, you know, like not spending all of my startup, plus the fact that CZT was beneficial. So I'm going to pass by this one, tell you why we put the title lower dose, because now having a detector with really good energy resolution, good spatial resolution, it means that when the scattering is happening, you have good way of knowing that is a scatter, and then you have good way of knowing the position of them. And then here is just really nice. Just pay attention. imagine that we have this, like the red one is 2 positron is coming, and then in this position is going to have a Compton scatter and get absorbed here. So then you see, if we have the exact position of all of this, we can create vector A, we can create vector B, the dot product, it gives us this theta LOR, and the kinematic of this process, it gives us like still like the energy of coming, changing direction, again, another theta, which is that theta of Compton. So you see that now if you get the things, the direction of which one was first and then the other one got a scatter. Like in this one, as if this is coming and now this is the position of the first interaction, then it is scatter, or you guess, no, it was this one and then it got a scatter. Totally that theta of LOR is going to be different. So you see, it's just like we are talking about these two. So then now we are utilizing basically physics of Compton scattering, bunch of mass of vector, and then with a simple algorithm that now you can imagine with machine learning, it can be very accurate. Whenever in the detector those Compton scattering happen, we are able to guess which position was the first one, because all we need for line of response is that first interaction position. And then before, like all the hospital, they were throwing bunch of information. Imagine your list mode is like, I don't know, like 10 gigabytes of data. At the end, those coincidences, they were like 100 megabytes. Why? Because the detector has a high probability of Compton scatter. You had no clue of what is happening because you don't have a good energy resolution. You don't have good positioning. So what can you do? So you have to just really, you don't want to give garbage in, garbage out. You just threw them out. But then now we are able to recover them. And then through their recovery, now we don't have to like image, let's say 20 minutes, we can go shorter, or we can have much better like image quality. And then this is just showing that in my technology, this is very working nicely, because for us to reduce the electronic, instead of pixelation, we use cross strip. And then that is going to create more ambiguity how you pair anode cathode, and exactly the physics is going to help us here. And then this is to show you that we wanted this system to be very modular. And then like this is showing that we did so much of how to make the engineering robust. And then, you know, like here I show you this like flexible electronics, they were really replaced with other stuff. So we have been through some revision of this. And then this is our first prototype. Pandemic totally kind of a little bit delay us, because now we couldn't get the detector actually fabricated. So then now this is like the system, the electronic is really good. This is what I show you. The red one is this new electronic we developed. And then this is like another system that we had at Stanford. The performance is much better. And then this is how we envision scaling up the system as soon as we receive the detector, and then we make the flexible circuit. And then where am I going later? So then so far we have this organ dedicated CZT system. We try to do a design with empathy. We make sure the electronic is like low noise. We create like a specific image reconstruction to kind of compensate for our design with empathy. And then now we are hopeful that by making this detector and being able to create sharp images, we can make a difference in, you know, treatment planning of the patient and help radiologists. And then where am I going with this after this system is built? Because for radiation therapy, it's really important to know even where is the hypoxia region. And then we are able to do much more utilizing this image that has good quantitative concentration of the radio tracer. And then let's say for brain imaging, for Alzheimer's disease, is really important to be able to image this carotid artery, that they are very thin. And I believe that with our system now we are able to image them. So with that being said, I just wanted to thank you all for listening to me. And then this is, you know, the picture of all the students that they have been helping me for the past 4.5 years, plus some of them that they are new. We haven't had to, due to pandemic, a new group picture. And then I'm happy to answer any question. So here we have, oh, thank you so much for Suzanne. My husband, he tells me don't have coffee because I'm so like excited already. Having coffee just makes me more excited. And then, and particularly grateful to hear mentioning design empathy. Yes, yeah, this is super important. And I make sure that I just train my students that they're gonna be engineer of tomorrow, that they consider that. And then we have Anne. I'm so glad to know amazing people. Oh, thank you so much. And yes, we are really determined. I'm going to build my career to lower the radiation dose. And thank you so much. So if there is any question, please put in the question and if I usually tell my students in the class that if you don't ask me question, I feel like either it was so boring or you did not understand anything. So to make me happy, ask question. No question? Oh, we have some more. Oh, thank you so much. Is the pandemic parts shortage affecting? Yes, like actually, I can tell you a little bit venting. Specifically, I don't know why there is shortage of FPGA, because we spend so much time, for example, for designing this, there is this board that is been very good, working well for us. It's called PicoZ board. And then this was a prototype, because in order to make the full system, we need 10 of them, because I had here that, you know, like having a panel of 20 centimeter, that's why this is 5 column of them. And then 15 centimeter, we are gonna stack the detector on top of each other. So I just wanted to make sure that we have the prototype, and then I order 4 PicoZ board. And then now that we have everything, and then I wanted to order, it wasn't available. And then like after I investigate, it sounds like there's all shortage of, you know, FPGA. And then this like the PicoZ board, they said that they are gonna let me know that it is coming. So then that was like, this is something that we are like put a deadline by end of this year, that maybe we have to change the design or something, which is going to be very like time consuming for us. And then the other thing is that like the detector fabrication, and then basically, because we get the raw CZT crystal that they are pixelated, and then we have to do like the bonding of them. And then like the bonding, since this is a very like unique, like is our design, so then it was like we could not find even companies that they are able to do this bonding. And then we had some few, and that we were happy with one of them, but then, you know, like pandemic totally delayed that process too. So we have been like doing our best, and then like I'm pretty sure hopefully NIH is going to give us like 1 year no cost extension to complete, to kind of compensate for pandemic. And then we have Tyler. What are some feature projects and potential goals that you guys have handling heading in 2022, especially with COVID becoming slowly so then like for me, I'm super excited now that we have the selenium facility, because before it was like, okay, to dream about different type of detector and then do simulation, but then nobody's gonna get excited till you show like real images. So then I think being in Silicon Valley, and then having company like Varix, Varian, like medical imaging company to provide us with like readout electronics, and we build like detector on top of them. I'm all about this opportunistic X-ray. So then that's something that definitely like I'm trying to put a proposal with like this Stanford PI for this like cycle, so that we build the detector, and then we show that this is going to be really good dual layer detector. So then that's one thing. And in 2022, since it's going to be the system for PET scale up, I'm really excited because recently we got like a supplement award for Alzheimer for brain imaging with UC Davis, which is going to be a start of me collaborating with UC Davis, which, you know, since we don't have medical school here. So then like we are going to head towards now, like really to me, for imaging, we use for diagnostic, but then for therapy, to me, like this is totally my personal opinion, as if the human body is like this black box. As an electrical engineer, we have the transfer function, you have input output, and then we have the patient body, we give them drug, we watch them, what is happening. So then when I heard the first time the term of diagnostic, like therapy, diagnostic, like I fell in love with it, because I think that like we have image guided therapy, but then with so many new therapy that we can have an agent that we can image during therapy. I am super excited to have like PET system and a SPECT system to be able to be more equipped tool for diagnostic. Okay, yeah, this is the two that I'm super excited about. And then mostly it was very over my head, no. However, as a teacher in our country, I love hearing novel ideas and thinking. Thank you so much. And then how do current diagnostic radiation doses compare to background radiation? Okay, so then like if we are saying months, years, like I don't know quite the answer to the question, but then I'm going to like calculate, let's say for a specific scenario, for example, we can say that how much of the background radiation we have of, you know, cosmic ray and stuff. And then if we say that, let's say, for example, for a mammography dose, if you want to calculate. So then if you have like, hopefully somewhere they put my lab and then you can get my email. If you send me email, I promise that I calculate that. And then we have this reduction of exposure is so important for those patients facing a lifetime of imaging. Yes, that's like to me our goal. And specifically now that we have even, you know, machine learning to like improve kind of a sparse imaging. So like I see very interesting work of, let's say, if you have some information that it wasn't, you know, like as high reach as before, they utilize AI to like reconstruct the image. And the other thing is that as you improve the time of interaction, because right now I was telling you, okay, two detector, they get trigger, and then you know the point of cancer is somewhere across this line. But remember, if you're able to make the timing super fast, you don't have to spread the information across like 1 meter of a scanner diameter, because now you can calculate the speed of light. You can know that if these two detectors, they get triggered together, which one of them got triggered faster, which tells you as if now the information, instead of spread across that line of response, is going to be confined. And then like I can see that like really within next 5 to 10 years, definitely we are going to get rid of, you know, some part of this image reconstruction that we do, because time of flight, if you say, I was talking about PET, as the electronics and detector technology is improving, you keep hearing more of tough PET, which is time of flight PET, which means that now you can guess even which detector trigger first. And then we have some system commercialized and available right now. Still, since the timing resolution is limited, so then instead of 1 meter, maybe they are able to say, okay, within few centimeters. But then, you know, like at least in my community, we have a challenge to go to 10 picoseconds. So if we calculate the speed of light and the distance with 10 picoseconds, we are able to really confine that within like 1 centimeter or something. So like we are doing our best. Typically, how long does it take for this new imaging technology to commercialize and reach mass adoption? I think that it takes, like for me, if I want to look at my PI lab, that's, like from the work that I was doing in my PhD, now is like getting to a commercialized product. And then it was like 2009. And then they are like having a product, like basically we work on it like from before even I joined the group till like I joined group, I graduated in 2014. And then like maybe within 2 years ago, this is like KA Imaging, my advisor in Canada company. Now they are making, some product that they can do images. So then I consider even like the other cases that I know is just like within almost a decade, at least at a school. And then I have no clue of like in a company, but I'm pretty sure it's going to be faster. Plus the fact that FDA is going to be approved. But then I think that at least within like KA Imaging, it took maybe 2 years for them to get FDA approval. So I don't know if that's a good time or like is it still long. And then we have keys. If you preferentially image something specific, such as cancer, can you add more energy and kill it? So then like this is happening. Like when we are talking about radiation therapy, that's why they give like much higher energy of like mega electron volt to kill the cancer. That's why like I'm saying that, Diagnostic is really cool, because in that case, I really don't want they bombard my thyroid or some healthy tissue when they are trying to like, give me radiation dose to kill the cancer. So then definitely we have that. Can you give an industrial application example outside of animal imaging? Also, can you give an example of technology for radioisotope detection? Yes, yeah, I'm really glad, because like we recently got like a grant from DOE that like we are utilizing kind of the same technology that we had for this head and neck, and then we are doing plant imaging. How cool is that? Because it's just like we are going to understand the kinetics of how like in plants when they absorb carbon dioxide, and then you have it as an input and then it goes through the soil of the plant. The interaction of this root and soil, since it's in vitro, since it's inside basically the soil, nobody could see it, and then you need high energy to be able to see that. So then like totally another application, it could be that. Or like, like in industrial imaging, because when we go, let's say we make this PCB, okay? So then they are very expensive. And then if there is a pass of copper that go through this printed circuit board is broken, I want to know, because there is no way my student can, debug it and figure out, oh, this was something inside this 6-layer PCB. So then having an X-ray to make sure that all the copper and layout of this printed circuit board is working well is another application. And can you give an example of this technology for radioisotope detection weapon airport container? Yeah, I think that I addressed that. I haven't like for gamma imaging. I think definitely in like for imaging, still for that we do work with non-proliferation, but that's like anomaly detection to make sure nobody is smuggling, any type of source. That's like application that, I do work on it. Okay, so I'm curious about the thickness of the detector. What difference do different thickness make? How do you determine the optional thickness? Yeah, so then you see, specifically since most of the technology today I introduced is a direct conversion, it's really important that is thick enough, because for any application, let's say, for example, for amorphous selenium, for mammography, which is commercially available, since the energy energy is 25 keV. If you go like, this is like NIST, which is National Institute of Standard, you can go NIST, and then you can get this attenuation coefficient, which is material properties of anything with any atomic number or density. It gives you a value. So then you want to calculate, so then it's just like the normal exponential equation. That's like e to the power of minus attenuation multiplied by thickness of the detector. So if you want to make sure that you can detect 80% of your input, so then you put, you know, I equal to I0, which is your like input, and then you want now the output to be just 20%. You put that, and then you can calculate based on what is your detector, what is that thickness. So then it has to do with your quantum efficiency. It has to do what type of material you use, and then what is your energy of incoming photon. So then to give you an example for mammography, for amorphous selenium detector, since mammography is 25 keV, we have 200 micrometer. Then for chest, which is like 70 to 120 keV, we have 1 millimeter. And then we cannot go higher because the technology of amorphous selenium, they cannot make a good detector defect-free that it can go thicker. So then definitely you have to like optimize like how much of intrinsic quantum efficiency you want, and then what is the fabrication technology, because it's not like as if 2 millimeter is good, you go and you make a bad quality detector. And the other thing is that when you are like, let's say, for example, for CT, because you shoot and you move. And then if you're doing, let's say, for fluoroscopy application, that let's say is like, it rotates in a way that you have 30 milliseconds to do things. So then it's really important that that product of the mobility, lifetime, and thickness of your detector, at the end, like if we calculate the unit, it gives you unit of centimeter. That should be smaller than the thickness of the detector. Why? Because that tells you that you have enough time to collect the charge before they die, and then have everything before, you know, like you're moving, and then you're not creating some sort of lag in your image that, you know, the effect of the previous shoot is like in your detector for the next shoot kind of. So then it's just like really nice kind of optimization. And then we have, thank you, this is totally not my field, but served as a great introduction for me. Thank you so much. Thanks a lot. Okay, so then I think that I went through these 14 comments question that we have. If you have more question, I think that we still have time. Please put in the question and A. Oh. And then, like, I should add comments in astrophysics. I think this CZT detector, maybe they can be useful. And then if here we have audience that they are working with UV, like since selenium has 2.2 electron band gap, is really good absorber of UV. So if you're interested in collaboration, send me email.
Hi, Shiva. Thank you so much for the talk. And sorry I've been in and out because the internet was unstable. And I just wanted to ask a question to close it. My question is very simple, is if you had like 3 wishes for how to advance the field, you know, of medical imaging, what would be those wishes? And what would be the result of obtaining them?
Yeah, so then my wishes, like my main wishes, it was if we could have no cancer. So then, but that's, I can't directly solve it because I'm not like an MD. So then like my wishes, like definitely one of the biggest one is to be able to utilize imaging exactly for diagnostic, because I believe right now as like immune cancer therapy and CAR T cell and all the new technology that it comes for cancer imaging is showing that they are very beneficial for patients. We have still really that black box approach that we tune the input and we look at the output with having no idea of what is inside this patient, which I think that imaging, it could be very useful. So that is like my first wish. And then for that to make it a reality, it's become, because right now you are not giving a dose of imaging to the patient, so you have to as if design your drug or whatever that you are injecting to patient to like cure them, to attach it with something that it's just like image, or by default if there is something that there are some interaction due to that in the body, that it's have some signature that you can image, you can use those natural signature. But for that, since definitely now you're like working as if with very, very, very low dose, so it means that in the detector side, right now we are just working with the like dose, the input as a like an imaging for diagnostic. So then it should be like more sensitive detector. And then definitely, I think the sensitivity is going to be like a deal breaker in order to be able to like have something that people, they can make sense out of it, especially if you just Google some PET or SPECT images, you see that, they are very like noisy. So then that's like one. The second one, is like I had it in my mind while I was just talking about the first one, is that so then I really right now I'm really excited that I think that is going to like the right direction. I hope that within my lifetime I can just really see those advances, because like when we have in optics that you see something and then now you are able to focus and then see it at cell level. I wish that we go to the hospital and then it was like this multi-modality, that it was totally like payable with insurance and then very easily workflow, that they could just image, and then at the same time of imaging, if they wanted to focus in a specific area or switch modality, or maybe they do it at the same time, they could get all the information basically. Because right now, as if we do some imaging and then, okay, so now based on that information, as if we have to say, okay, so then maybe there is a need for another imaging modality. And then always in those cases, since there is two different, image, fusing them, patient, it's not even the motion, it's just totally like two different condition. Even especially some of the things that I joke is that usually they inject patient with the tracer, they wait for 1 hour, they send them to like discharge to go to restroom before they send them to imaging. And then sometimes I was just joking that we want to make a toilet, which is a dosimeter, because like, how do you know for cancer, like in the bladder and around the lymph node? So then based on how much discharge from one time to another time the patient had, like how you're going to make a sense of what was the progress of this drug over that drug. So that's why I think that if there was things that we could do all at the same time, within like this multimodality, that it could go from the macro to macro to like very cell level, like that was like one wish. And then like the personalized medicine, I think that is coming, is just something that I could wish like maybe longer time. And then I'm really excited to see how we are having this whole approach of based on, like different radiomic and then images, how we can really treat a patient like very personalized. That's something that I'm really excited that is happening.
Thank you, Shiva, so much. Unfortunately, I cannot grant you those wishes. I'm not at the power to grant those wishes. And I also counted 4 instead, I think so. But I'm sure there's many things that are amazing in your field. And I just wanted to thank you again for the amazing talk. And I was gonna pass I don't know what it is, the baton, the microphone and the camera back to George for concluding remarks. And thank you everybody for attending.
It's the microphone and the camera, right? So thank you, Shiva, for sharing this important research with us tonight.
My pleasure.
And please join us, all of you, for our next Kraw Lecture on September 22nd with Professor Sarah Abramson, Refractive Optics in Microscopy. Good night, everyone.
Bye.